Vision Edge gives you less eye strain and reduced damage caused by blue light. We like to call Vision Edge sunscreen for the eye. It all starts with your highest level of visual performance, only achievable through scientifically proven Vision Edge.
Welcome back to part 2 of my interview with neuro-ophthalmologist Dr. Alberto Gonzalez. In this episode, Dr. Gonzalez discusses retinal migraine, eye findings seen in stroke victims, and how the examination of the pupils help diagnose systemic neurologic disease. If you like our interviews, press like, subscribe, share, and hit the bell to get notifications of great new interviews. And please leave comments. Let's talk about pupils. People that come in and their one pupil is bigger than the other pupil, all of a sudden they have a big pupil. What does that mean? How serious is it if they have a big pupil and their eyelid is drooping? Talk to us about the different possibilities.
Right. One, and to link into what we spoke before, one common source of anisocoria, that is called, the difference between the diameters of the pupil, it's migraine. Sometimes migraine can create, especially during the crisis, you will see that one pupil will be different than the other one, or diameter will be different than the other. And most of the time it's an easy diagnosis because it's usually linked to the headache that comes after or with it. Sometimes migraine doesn't really express as a headache. And that is when the problem comes in, because most of the time it's what we call, it's a rule out diagnosis, right? There is no really a single ancillary test that can be pathognomonic or can help you make the differential diagnosis. But most of the time is related to fortunately is related to the headache, and you can counsel the patient, say, no problem, you can be like that. We should also start that it is normal to have a differential in pupil up to 1.5 to 2 millimeters. If you have that difference, that could be completely normal and not necessarily be an expression of a problem in your eyes or your brain. Another difference could be diabetes. It is well known that diabetes causes a lot of pupil, myopathy. Cataract surgery, because of traumatic, that will fall into the traumatic, asymmetry in pupils. But, like you will said, you always must start with those causes that might put the life of the patient in danger, right? Like either stroke or tumors, which is the most, I would say, or aneurysm, any other kind of affection of the nerve that can affect the pupil size. It could be because you have like Horner syndrome, if you have any issues in the sympathetic pathway, or if you have like a lung tumor. You can have stroke. If you have a third nerve palsy, you can, like you will describe, you will have the you have the pupil difference, you have drop in the list, and you have strabism. So depending on all this sign and symptom that come together with the difference in pupil, then you can differentiate. You can also use the reaction to the light. When is the pupil more different, in the dark or in the light? When is the if it is reactive or not. If it is reactive, it might be just a physiologic asymmetry. Or if it is a female, you can think about Addy syndrome, right? That tend to create those in the time change on the pupil because of the insufficient motility of the muscle, that right, at the sphincter of the pupil. So the different toxic, like of course, drugs can create mydriasis, but most of the time is bilateral. So different definitely causes can affect this pupil asymmetry.
What's amazing is how the eye and the body is connected. There's a lung tumor called a Pancoast tumor that could cause changes in the pupil and cause a Horner syndrome. If you could just quickly explain that, how the lung could be related to the eye.
Yeah, what happened is that the eye, the way it works, the pupil works, is two main functions: contraction, dilation, and each function is commanded or is executed by two main muscles within the iris, the sphincter and the radial muscle window. These two group of muscles are innervated or are connected to what we call two different group of or nerve system, which is sympathetic and parasympathetic sympathetic system, and one of them actually the nerve goes down to the spine and it gets close to the apex of the lung. So when there's a tumor in the lung, that like the pancreas that you just described, it can compress that pathway and it can affect the function of the pupil.
Excellent. Now, let's talk about some of the symptoms that could affect the eye from Lyme disease.
Lyme disease, it's unfortunately a very devastated, it could be very devastated disease. And probably one of the reasons is because, different from many other infectious, it can be latent and can be in your body for many years before they express itself or had come up with symptoms. The Lyme disease can affect in the eye, can affect every single structure of the eye. But one of the most commonly affected is the optic nerve. And it can cause what we call, it's a cause of one of the optic neuritis. But Lyme disease can also create what is called encephalitis. And the encephalitis, because of Lyme disease, can affect virtually any aspect of your body. So it depends on where the focus on infection happens. If it happens in the stem, stalk, then it can affect the eye movement. If it is on the optic nerve, then it can affect the vision of that specific eye. If it is on the motor, then you can have a paralysis. So depending on where that focus of infection happen, then you will have different symptoms. So there is no actually a single symptom that you might have that might not be related to a Lyme disease because of the affection of the brain. And unfortunately, the eye, and especially the optic nerve, can be a focus, and the retina, of course, can be also a focus of of the infection that, as it transmits because of the tick on the deer. And it is more common in the northeast or the north of the country than actually the south. So it depends on all this. Geographical also condition can also help you to pointing out. It's more affected the rural and the urban areas. So there are different information that you can get from the patient that can, direct you to the diagnosis of the disease.
In eye care, to help us with the diagnosis, there's a lot of technology that we use. Let's talk about the different technology used in eye care by optometrists and ophthalmologists. Let's start with our favorite, your favorite, the visual field, something you've been working very hard on. Talk to us about how the visual field is important and the next generation of visual fields that Olleyes is working on.
True. The visual field is the perimetry, is the technique that allows the doctor to understand the status of the visual fields of a given patient. And by visual field, it's all that area of vision that we have surrounding the central vision. All this area, like for example, while I'm looking at you, I can, without taking my eyes out of you, I can see, right, my bottle of water. I can see all the things in my office, right? And that's because of the visual field. That it comes with a very old phylogenetic, development, especially from where we have to be very aware of the lions, right? So people have to be very, very cognizant that there's coming. So any little movement will, grab the attention and escape right away. So visual field is very, very important. It saves us from being, hit by a car when we're walking on the street. So it's a very, very important vision that part of the vision that unfortunately is affected by many diseases like glaucoma, tumors, multiple sclerosis, endless. Many, many diseases affect the visual field, but very likely the one that are known the most are glaucoma, right, and tumors or ischemic disease of the brain. And these techniques basically that we use have been evolved, right, since, the ancients, that we can use just our fingers to understand what we call confrontation visual field, to a manual tangent screen showing the patient, a technician showing a little stimulus to the patient in a wall, to a automated perimetry in the office, which is what is being used the most in the last decades. Basically, the patient sits in a relatively uncomfortable position and looked into a bowl, and lights will turn on, and the patient has to indicate when to turn, when the light is seen. And that allows the device to automatically understand the status of the visual field. What we're doing different is that we're taking advantage of what is well known virtual reality or augmented reality, or what we call in general mixed reality. And the advantages of this kind of technology is we can divide it in two. Those advantages for the doctor and the advantages for the patient. The most important, of course, is the advantages for the patient. And the first one is the comfortability. The patient now, instead of being leaned forward, very uncomfortable in a very static position, now they can relax and they can wear the headset and run the test in their more comfortable position they prefer. The second is that during the test, they don't have to be static. They can move. They can move their head without needing to stop the test. The other is that because everything is automated, we have within the headset all kind of tutorials to help the patient understand what is this about, what is the test going on. That allows a more independence from the technician. And that means that now the patient have more time and less stress to do the test. When the technician is controlling the test, unfortunately, it is against time because the technician has to see all the patients, right? Now with this platform, there's more independence and the patient can do the test not only at the office, but from anywhere, including their own home, which is one of the greater advantages of this technology. In the near future, the patient will use this at home. We already started all the studies. We finished the feasibility with awesome results. And so we now are convinced that this can be used at home. The patient can run the test not only once or twice a year. They can run the test virtually every day if they want. You don't have to, but you can do it every day if you want. And that means something very important. The significantly increase in data, amount of data that now the doctor will have for a much reliable evaluation of the visual field, especially for the detection of progression, right? Sometimes, like you well know, when you are evaluating a patient with glaucoma, there is no definitive diagnosis, right? And you have to follow those patients on time. And only when you detect a change is when you trigger all your measurements, right? Treatment, so etc. Well, the earlier we can detect this progression, the better the probability to improve and avoid the disabilities. There's other groups of advantages for the doctor. First, their quality of care increase exponentially because the patient compliance increases. You very know well that every time you tell a patient, hey, we need to do a visual field, their face goes like, again, those. What we're seeing is a 95% of the patient, they go like, oh, but we're going to do it with the cool stuff, right? With the virtual reality. And they actually happy to do so because they're very comfortable. There's no stressful experience anymore. So that is one of our goals. Change the perception the patients and doctors have about perimetry and many other psychophysical tests.
There's a test very similar with macular degeneration, the 4C home, which the patient takes 2 or 3 times a week to see if there's any change, to see if a patient goes from dry macular degeneration to wet macular degeneration. How many times a week, or it would be once a week, twice a week? I know you say they can do it every day, but what would be the recommendation? How often do you think a patient, if they can bring this instrument home, how often should they do it? And then the doctor, I assume, will get an alert if there's a progression.
Right. It will depend on the disease that we're using the visual field for, of course. If you're a patient with glaucoma, stable glaucoma, that well compensated intraocular pressure within expected levels, then probably once a month will be totally enough. If this is a new patient that just came to the office suspect of glaucoma, and you would like to create your baseline for that perimetry, probably you want to do it every week. If it's a patient with glaucoma, but it is not well compensated, if you know that the pressure is fluctuating, then you probably want to do also weekly. If the patient is progressing, then probably you also would like to get more data. So it depends on specific kind of patient. For example, we have a group of patients also that are getting injections within the eye. And the doctor will like to see what is the behavior of the visual acuity and visual fields almost daily. Like once every other day, they want to understand how that vision progress, because that will allow the doctor to understand when is the right moment to bring back that patient for the follow-up injection. So it changed depending on the disease. Let's say you have a patient with a brain tumor and the patient is going into a neurosurgical procedure. Then you probably would like to create a very basic, well-established visual field test, and you will give the patient, let's say, 2 or 3 weeks before the surgery to do it almost every other day, or every week at least, to have that baseline and understand whether there is a problem after or not the surgery. So it depends. It's a relatively new technology that we are now learning more and more and more, especially about the frequency that we have to accomplish this. But very excited about, helping doctors and patients to improve the quality of their care.
There's probably different types of programs and different types of tests, but the average test for glaucoma, how long will it take each eye and both eyes together to take the test?
That's a very good question. When the perimetry was done at the office, there was a huge interest to decrease the amount of time expended on the test, because two things: the greater the amount of time you expend on the time, more you can get tired, you can get unfocused, and the quality goes down. We know that. But we also now that there's a threshold of time that if you go beyond that, then the consistency and the reliability of the test gets affected. So in the office, it is accepted that between 3-4 minutes per eye is a relatively decent amount of time. We have that also in the home model, but at home, the timing of the test is not anymore a problem for many reasons. First, because you can stop and pause the test at any time and continue at any time, right? You're doing the test and then, honey, the dinner is ready. You stop the test, you pause the test, you go and have your dinner, and you can finish the test tomorrow, no problem, right? So that there's no limitations anymore. That's why we are not, for that reason and other very important, we're not pushing to make a test of like a 1-minute test. Having said that, this is another very important concept in eye testing and eye care, which is the personalization of the care. The current perimetry use what is called a normative reference data in order to understand what is the probability that a given result is expected or not, right? And what we do basically is that we create a single model, and everybody have to go through that single model for us to understand whether it's normal or abnormal. We already know that that is not the case in real life. We know that every single patient progress, or the follow-up is completely different. So many specialties in medicine, especially oncologists, are going into what is called personalized medicine, which means that the most important is not the relationship between you and what is considered by the community as normal. It's comparing you against you to understand when there's a real time or when there's a real change in your progression. That's also a model that we are pursuing, because it being proved to be more efficient for the evaluation of the patients.
Do we know the cost of this? If a patient is going to go home with one, will it be covered by insurance, or those are things that are going to be being worked out as we speak?
That's a very good point. Actually, in January 2019, CMS came out with 3 permanent codes for what they call remote physiologic monitoring parameters. In other words, the CMS, the Medicare, created the tools to reimburse the doctor when the doctors evaluate those parameters remotely. So right now, there is already a vehicle to establish this kind of follow-up. And basically, it is a monthly payment that, depending on how frequent you use the test, can go from $52 to $160 if it is very frequent.
And how about the patient having to buy the instrument? How does that work?
It depends. Right now, the patients are acquiring the device. The cost for the Visual H, which is the home model, it's $799. It's less than an iPhone. But it's still linked to the Visual S, which is the home office model that the doctors acquire. And basically, because this is not a test that the patient wants to do every time they want, it should be still a test that is prescribed by the doctor. So the doctor, through their platform, control what is the frequency and what are the results of the test that the patient performed at home.
Let's talk about OCT, optical coherence tomography. How could that help in neuro eye disease?
Oh, the optical coherence tomography came up in the early 90s. Of course, it started in the 80s, but the commercialization started in the 90s and has evolved through a way more efficient models. It came from time domain to spectral domain or Fourier domain that we also call. And basically what it does, it takes a picture, to call it that way, of the eye, but not of the surface of the eye, but actually the eye in depth, right? And this kind of pictures allowed the direct visualization of the neurons within the retina. There are many neurons in the retina. The photoreceptors are neurons, the bipolars are neurons, amacrines are neurons, ganglion cells are neurons. So all the retina, it's composed by many neural components, and we can directly observe and measure and quantify the thickness and the volume of those neurons within the retina. And we already have evidence that the OCT can detect decrease in the thickness of these neural components when you have diseases like Alzheimer's, Parkinson, and many other neurologic, especially neurodegenerative conditions.
Macular degeneration is a leading cause of vision loss, with 15% of Americans being at risk or already affected. Scientific evidence proves that by using mesozeaxanthin, lutein, and zeaxanthin together replenishes the macular pigment and promotes healthier vision. This formula comes in only one product, MacuHealth.
Thank you for tuning in to the Open Your Eyes podcast. If you like the video you're watching, please hit the like button. Also, hit subscribe for weekly new episodes of the podcast, along with pod winks and bonus content. All right, let's get back to the show.
Do you feel that the eye doctor at some point will be the first doctor to be able to diagnose who's at risk for Parkinson's or Alzheimer's disease based on OCT?
It is already. The evidence is there. What it is limited right now is the differential diagnosis. So we know that if you are a person with 80-year-old, your pressure is normal, there's no signs and symptoms of glaucoma, and you have a decrease of the thickness of the RNFL, you probably will like to have that person evaluated by either a neurologist or by a internal medicine in order to look for all those signs, that of course, uh, it depends, of course, of the eye doctor, right, that's looking at. If the eye doctor is familiar with those symptoms, they can somehow participate in the management or that side of the management of the patient. Most of the time, the patient will be referred, of course, but the same that happens to Alzheimer happens very common to diabetes. It's so common right now, right? That diabetes are diagnosed by eye doctors because they take a picture and this is the reason why Google performed this amazing study about artificial intelligence to evaluate pictures of the fundus of the eye for the fast and automatic detection of diabetic retinopathy. Not only that, now they can also detect if you are at risk to have a stroke just by a picture of the fundus. So you are very right. We, or eye doctors in general, are going to have in their hands the tools to save many, many, many lives, to prevent the complication of those diseases just by a single evaluation of the eye. And I don't want to minimize the importance, but by single, I mean a given test, an OCT, a fundus photograph, or a thorough, examination of the retina.
The eye doctor is a very powerful piece of primary care for prevention of systemic disease. And this explains exactly what you're speaking about. You mentioned a stroke, that we could see if somebody's at risk for a stroke by looking with a photograph. Go into that a little more detail. What could we see?
Before I explain that, I would really like to mention here your work. I was in the last weeks, I was looking into all the materials that you have put together related to a very important concept, which is putting together the eye with the rest of our body, not only in the neurological way, but also metabolic way, nutritional way. So the job, I will really, I'm very happy and very proud of, knowing you, because I think you are doing a great job in putting together and linking this to way which sometimes it's not okay, unfortunately, in the current community. So I think your job is very, very important, and I would like to, congratulate you for what you're doing.
Thank you for that.
The specific signs and symptoms that all these algorithms are looking into it's most of the time related to the vascular aspect within the eye. So one of the advantage of the ophthalmoscopy or the fundus photography is that you have access to blood vessels, right? It's probably one of the few, for not to say, there's only few structures in your body that allows you the direct access to the vascular branches. And the status of those can prevent this kind of a stroke, which are nothing but a vascular and blood disorder, right? So They can look for what is called embolism. Sometimes they have like little pieces of either cholesterol gas or many other systems that can be visible within the branches. It can look into the diameter of the blood vessels, the decussation of the blood vessels. So several signs. There are aspects and ischemic areas within the retina. We know, for example, that if you have an obstruction of the veins in the eye, that puts you at risk from the rest of the population to having a stroke. So there are many of these signs within the eye that can alert the doctor. The way this algorithm works are totally different. These algorithms are, and to be honest, I don't even know exactly how it does, how it works, to be honest. But basically they looked at every single pixel within the picture, and not only they looked at those pixels individually, but the relationship with the rest. So it's a very complicated algorithm that our brain couldn't do it at least in a voluntarily way, right? But fortunately, we have computers, and very potent computer right now that can do this kind of algorithm and help us with diagnosis.
Talk to us about how we could use extended color vision to help us with diagnosis of different disease.
Sorry, extended what?
Color vision, using color vision.
Oh, color vision. Okay. Yeah. The color, it's actually, for some reason, actually underutilized unfortunately, in the community. And the color, and the reason why, it's simple. It's probably the function within the eye that we understand the least. Color, it's a very complicated mechanism or function of vision. Vision have, different functions, right? We have the acuity, which is basically how small objects we can see. We have the visual field, which is what we explained, the extension of that area of vision. We have stereopsis, we have contrast, which is the difference between the luminosity of two different surfaces, and we have color, right? So color is just one aspect of the entire vision, but probably the one that we understand the least. There are, as you know, three main kind of neurons within the eye responsible for the management or responsible for the capability of seeing or seeing now to bring the information to the brain about different colors. It is very, and I don't mean in a disappointing way. I don't mean in a, even in the, I don't want people to be stressed because of this, but there are no colors outside. Color is just an illusion of our brain to enhance the vision. Sometimes there are objects in the outside world that they have exactly the same luminance, and we wouldn't be able to differentiate between these two objects unless we have that color information. So the color function, it's another way that our brain evolved and have to understand and help us differentiating objects in the real world. And the way they're doing is basically we have these three neurons, three or photoreceptors that we call the L, the green, red, and blue cones. And those cones and the combination of these cones allow us to detect those differences. When we have color deficiency, depending on the color axis that is affected, then we can understand whether the problem is congenital, whether the problem is acquired. As you know, we have two main, the color function travels to the brain in two main axes, right? The red-green and the blue-yellow. If you have a red-green affected, which is the most common one, right? It's most of the time a congenital condition. It's up to 8% of the male population have, unfortunately, this color vision disorders. And we can use simple tests like the Ishihara test, or we can go, more complicated like Farnsworth Munsing hue test in order to detect that deficiency. Or you can use all the tests like the Farnsworth or the D-panel D15 which is sort of about just a variation of the original Farnsworth, and go into the blue-yellow axis that most of the time is an acquired condition, which is, by the way, another technique for evaluating perimetry, right? And the reason why we do this is not because these blue cones are more or less sensitive for conditions like glaucoma, is that there are very little amount of them in the retina. So if you have a disease that is affecting all of them, the blue yellows are gonna disappear faster. So we can still use that knowledge in order to detect this kind of condition. There are specific conditions. There are not congenital but hereditary that affects specifically these kind of photoreceptors, but we can use it to evaluate whether the problem is more in the macula, whether the problem is more in the optic nerve. So the color vision is a very, very useful tool for the evaluation of the function and also to understand the status and the degree of affection of the vision in these patients.
To help us with earlier diagnosis of glaucoma, the blue color vision, can you just explain that quickly?
Yes. So remember we mentioned we have three main cones, right? The photoreceptors specified for day vision, right? Which is the red, green, and the blue. The red and green are many, many, many photoreceptors. There are probably I think it's about 90 to 80% of all the photoreceptors, if not more. The blues cones are very little. And those blue cones are connected to specific ganglion cells that form a pathway that goes to the lateral geniculate nucleus, which is a structure within the brain. And that pathway is what we call coniocellular pathway. That pathway, it's probably 5 to 10% of the entire magnocellular, and parvocellular pathway, right? So those three, the conio is very little, which means that if you have a disease that is affecting all the ganglion cells, right? Let's simplify this. Let's say you have 100 ganglion cells. And of those ganglion cells, 10 are blue, to use also simple language. If you have a disease like glaucoma that is affecting those ganglion cells and is killing ganglion cells, let's say, and they are all sensitive the same, then you lose one blue and one red, one blue and one green, one blue and one red. At some point, you still have 60% of the reds and green and zero blue. So if you have a test that specifically look for this kind of ganglion cell, you can early on detect the disappearance, or even earlier, the dysfunction of those group of cells. And that is the principle of the SWAP perimetry, or short wavelength automated perimetry. The evaluation, the specific evaluation of those group of cells looking for early signs of glaucoma. But it's not only specific for glaucoma, it can be done for other neuropathies that affect the visual pathway.
Let's turn our attention to contrast sensitivity. How can we use that to help us with diagnosis?
Contrast sensitivity is my favorites of all the tests. Contrast sensitivity is the basic of all the visual functions. It's the basic for visual acuity. It's the basic for perimetry. It's the basic even for color. It's just that it's a different contrast. But contrast sensitivity, probably what we more commonly know as contrast sensitivity test, it's basically to show the patient optotypes or letters or figures that their contrast compare with the background changes. In other words, you can start with a very, very dark A letter in a very, very white background, and then degrade that A letter or E letter, any letter, from very dark black into gray degradation that get close to the white of the background. The closer or the smaller the difference between the letter and the background that you can detect, the better your contrast function and the better your function in general. Unfortunately, and for a reason that I don't understand, it is not a cover test, unfortunately, by CMS. It's not covered by all the payers. And in my opinion, it should, because it's the most sensitive test we have. Much better than visual acuity, much better than color. It's one of the functions that we lose early on when we have virtually any disease in the eye or the optic nerve.
There's now a test for measuring pupils, so the pupil response. How important could that test be and helping us? Should we use it as a screener on everybody, or should we just use it when we suspect a disease, if somebody has a disease?
As you know, the pupil measurement is part of the general examination. So having a machine that does that for you automatically and can extract the subjectivity of the observer, it's definitely a huge advance. And in my opinion, it should be actually part of the regular examination, because sometimes our subjectivity or the environment where we're stimulating or the time that we have to examine the patient, sometimes those examinations can miss very subtle changes. But even more important, even if we make a very, very conscious examination, our subjective examination of the pupil can miss small changes that the machine can definitely detect. So I would say that in an ideal world, this should be a examination that this should be part of the every patient routine examination in your office.
Excellent, because it's going to be a lot more sensitive than the doctor could do it. And
Of course.
it's going to pick up things from glaucomas to brain tumors to who knows what, because this is new technology that has been improved on quite a bit, and the new models are starting to come out.
Correct. And it is worth a comment that is totally independent of how good or bad is the doctor.
Right.
It's a human limitation. It's a really human limitation that we have, that we are limited on the quantification. We have a very subjective, of course, analysis of the world that is around us.
The last test I want to talk about is something you're a world expert on. You spent a lot of your life involved in, is electrophysiology. Can you talk about how electrophysiology could help us with early diagnosis to be able to help our patients?
Right. The electrophysiology is a very, very old technique. It's a very old science, probably one of the oldest in neurology and ophthalmology and optometries. The electrophysiology is based on the principle that every single function in our body is commanded by electricity. We can speak because our brain sends electricity to the tongue and the tongue moves. We can see because our brain, our eyes collects the visual information, convert that light information into electricity, and send that electricity to the brain for the brain to understand. So, and because we are alive, because the electricity make our heart pumps, right? So electricity, our body works fully based on electricity. So if that is the basic of all our function, measuring that functionality will allow us to understand how well our body is working. The same way a cardiologist will do an EKG, an electrocardiogram, in a patient to understand whether it's an arrhythmia or whether it's an ischemic condition or a blockage, whatever happened in the brain, the same we can do it in the eye. We can stimulate the eye and collect that electrical information either from the brain or directly from the eye in order to understand and quantify the function of these two or the entire visual pathway. And the advantage of the electrophysiology is that, like the pupillometry or video pupillometry, is that it's objective, right? It doesn't depend on what we call the double objectivity. It does not depend on neither the subjective response of the patient nor the subjective evaluation of the doctor. So that is definitely a huge advantage. That doesn't mean that it is more or less important than other tests. I believe that subjective tests are still very important. And a good example is the autorefractors, right? We have autorefractor. We have a way, a tool to understand exactly the refractive error that we have in our eyes, right? Since probably the 70s. I think I was very young, but we have had autorefractor for decades. and we still ask our patients, better with this, better with this. And the reason why you do it is because we all perceive the world different. And we cannot put it all together in a single, unique way. You have to take into account the subjectivity, because as you know, vision is not only our eyes, vision is also our brain.
So talk to us about the difference between the VEP and the ERG and what they could tell us that's different within the optometrist's office.
So VEP and ERG are very good techniques for the evaluation of the brain and the eye respectively. So if you do an ERG or electroretinogram, basically what you're doing is you are placing a sensor close to the eye and collecting the electrical activity that is developed within the eye because of the visual stimulation. The visual potential is exactly the same, but instead of collecting that electrical activity from the eye, we collect that activity from the brain. And what that allows us is to understand, for example, how long it took for that information to travel from the photoreceptors in the retina all the way to the brain. And this is a very important information because diseases like multiple sclerosis will delay the conduction of that information. In fact, at some point, the VEP was evaluated to be part of the McDonald criteria for the diagnosis of multiple sclerosis because it's so important for sometimes the subclinical detection of this kind of disorder. In other words, you can have 20/20 of vision and still have an abnormal visual potential if you have an optic nerve disorder like multiple sclerosis. So those are the difference between the visual potential and the electroretinogram. One study, the ERG study, will collect the information of the eye, and the other one collects the information of the brain.
So again, how the eye and the brain are related, it's just, together. So to be a good eye doctor, you also have to be a good doctor of the whole body, including the brain. So I really want to thank Dr. Alberto Gonzalez for joining me today. You made a very complicated topic very simple. And I want to thank you for that and spending so much of your time and giving of your time. I really appreciate it. If somebody wants to find out more about you and Olleyes, how can they do that?
Oh, it will be a pleasure to connect to anyone interested, whether from the doctor community or patient community. They can find us at olleyes.com, OLLEYES.com. And that is the website of our company where you can find all the technology that we're developing, and especially the mission that we are, involved with, which is bringing efficiency and much greater quality to the eye care.
Again, I want to thank Dr. Alberto Gonzalez for joining me today. This is Dr. Kerry Gelb for Open Your Eyes.
Thank you very much, Gary. Thank you very much.
Since I bought Safe For You, my dad makes me clean his boat.
Es natural y es un buen producto.
Every time I go back to school, my mom always makes sure that I have my Safe For You products. I like to bring extra, and my roommates certainly don't mind.
It's a good thing I had Safe For You to clean up after this little guy.
When my hands get dry, I like to wash them with Safe For You.
And most importantly, the reason why I buy Safe For You is because it's safe for me and you.